Welcome, Katie.
Thank you.
The good
So
mood
happy to be
Mondays.
here.
Yeah, thank you. Yeah, this is awesome. This is something we've been trying to get into the works for, like we were saying, a couple of years. So I'm excited.
Yeah.
Yeah.
Yeah. It's been a long time coming for sure.
And the topic of the day is thyroid, a very
Yay.
important topic that we haven't covered on this podcast. And so let's dive in. So maybe you could tell us how you got into thyroid health. Because I think it's been a few years that you've narrowed your focus more.
Yeah, it's been probably getting close to like the 6 or 7 year mark of me working more specifically in thyroid care. And like I'll admit it openly to everyone. When I was going through school and even in like our clinical year, thyroid was not something that I was interested in. I did not enjoy it. Like it seemed very complicated and confusing, and I just was like, oh, I just won't see thyroid patients, which like now is laughable for multiple reasons. But when I came out into practice, I found, I was seeing a lot of the same people coming into my office, as far, primarily women who had been diagnosed with a thyroid issue, taking thyroid medication, but they were still experiencing a lot of these chronic, potentially thyroid related symptoms. And they weren't getting any additional care or support from the other parts of their health team, and they were looking for answers. And so that is kind of what's, started my journey into thyroid care. And then I decided to do, some testing or a full thyroid panel on myself, and found that I had positive thyroid antibodies, which we can definitely chat about and what that means and how we want to, go about assessing and treating those. But that obviously, just increased my personal interest and investment into thyroid care. So I spent, a good 2 years just taking every course, reading everything I could, narrowing down my practice. And now I really see probably 95% of my practice is thyroid based. And I do, a lot of thyroid focused education and courses and things like that for other practitioners as well. So it's been a really cool journny for me.
That's so funny that you start off being like, I'm never going to work with
Yeah,
thyroid
right. And
specifically.
karma's just like, you just wait, girl.
It's like you will be teaching the other practitioners. Yeah, I took your course
Yeah.
probably the first year it came out, I think. And really fantastic. So for any practitioner listening, you should get on this. You also get CE credits for it. And yeah, really great, because you can tell that you dove there's obviously like a personal spin on it. Like you can usually tell that with people when they're like, I've had to do this research not just for my patients but for my own
Yeah.
healing, my own self-healing. But you can tell that you've dove into all the research, like conventional, the more holistic type research. So really fantastic. And maybe we could start by talking about like, what is a thyroid? I'm sure people have heard about thyroid issues and maybe
Absolutely.
Googled symptoms, but maybe are unaware of what exactly we're talking about. So yeah.
Yeah, I'm gonna pick on my husband a little bit. He probably won't listen to this, but he does. So as I was like getting more and more into thyroid medicine and care, he was like, so like a thyroid is like a real thing? Like I just thought it was like a hormone that's in your brain. And I was like, no, like it's actually a gland, it lives in our body just like a spleen or a liver or, our adrenal glands. So a lot of people don't know what our thyroid is, unless you have a thyroid issue, and then you know everything about a thyroid gland and what's going on.
Right.
My most educated patients are often my thyroid patients, because they've had to become so educated and advocate for themselves. So yes, our thyroid is a gland. It lives in the bottom of our neck, and it produces our thyroid hormones. And our thyroid hormones are essentially, our basically gas or our like metabolic energy for our body. So our thyroid hormones travel all over our body and enter into every single cell in our body and initiate or activate that cellular energy. So when you go online and Google thyroid symptoms, you basically come up with a list of like 100, 200 different symptoms. It's anything from, low energy to constipation to depression or anxiety, which we're definitely going to talk more about, to swelling and puffiness, hair loss, so such a long list of symptom. And that is because, every single cell, every part of our body requires thyroid hormone. So it can result in many different types of symptoms, which is, very frustrating, but also very, interesting when we think of the importance of thyroid hormone in our body. It is so, so crucial.
Maybe this is why your husband was like, is this just not like some woo thing? Because it can account for every symptom that anyone's
Literally
ever experienced,
everything.
from psychosis to like brittle nails. To like anything.
Yeah. Simple things to very complex things, for sure. Yeah.
Yeah. And I think like when we think of what we see as NDs, and we'll get more into this, but we see a lot of fatigue. We see things like hair loss and low libido and irregular periods and PMS. And we see a lot of things that are troublesome for people, but that don't necessarily get a lot of attention or concern. Because if they're not, life-threatening symptoms, then often doctors will, like GPs, like conventional doctors will be like, well, there's nothing really we can do here, or this is just sort of what it's like to get older, even though you're 27. And so a lot of people are like left to kind of Google, and then they usually thyroid will come up. If you Google fatigue, like that's going to be one of the number one differential diagnoses that comes up. And and so, how does the thyroid, maybe we'll start there. Like, how can the thyroid go wrong or become imbalanced? And how does that connect to, let's do anxiety and depression, because those are the most common mental health conditions that probably people are dealing with. But like, how does the thyroid connect? It connects to everything in the body, but how does it connect to mental health?
Yeah. So I think there's obviously multiple layers that we can chat about, but on a purely like physiological basis, when I talked about thyroid hormones, going into every area of the body and entering cells, the brain is one of those areas. So our thyroid hormones enter the brain, they enter the cells in our brain. Thyroid hormone is essential for brain development and brain function. And like I said, it's that metabolic driver. So without it, that cellular function is really impaired. And if their cells in our brain are not functioning optimally or not firing optimally, then our brain function can absolutely be impacted in many ways. So that can certainly impact mood, low mood, anxiety. You mentioned like even more concerning or things like psychosis, or, that can absolutely happen when there's not proper thyroid hormone levels in the brain, because our brain cells are essentially not functioning as they should be. And that can also include other, cognitive symptoms. So not only depression and anxiety, but we also see things like brain fog or trouble concentrating, memory issues, feeling forgetful, just feeling like you're living in this kind of slow, foggy, brain feeling is something that a lot of my thyroid patients speak about.
It's like, one of the more common symptoms is that brain fog. And if we look at like hypothyroidism, which we might differentiate between hyper and hypothyroidism, the symptoms and the symptoms of depression, like low energy, hypersomnia, sleeping more than 9 hours a night, changes in appetite, changes in weight, and the low energy and motivation is also can sometimes look like an apathy, right? An anhedonia. You're not really interested in doing the things you used to be interested in. So that superimposes directly with hypothyroidism. And we don't have like a necessarily like a specific hormonal cause of depression. And in many cases, and maybe see this in your practice and maybe no more percentages, but like a lot of people that are diagnosed with depression might have an underlying thyroid issue, and that might be the cause of their symptoms.
Yeah, I think that, you touched on a lot of important points. Like there is such a huge overlap between the
Mhm.
symptoms of depression and symptoms of hypothyroidism. So I think it's always worth for, patients who are experiencing, depression or low mood or anxiety to have their thyroid, properly assessed to see if that is playing a role in their mood symptoms.
Mhm.
We definitely do see a higher risk of depression with hypothyroid patients, and up to 60% of people with hypothyroidism have low mood or depression. Like that's a huge,
Mhm.
huge percentage.
Mhm.
There was a recent study out of JAMA Psychiatry. So really, top-notch journal in
Mhm.
2020, looking at anxiety and depression in people with autoimmune hypothyroidism. They looked at like over 19 studies, like over 30,000 patients. And they found, basically echoing the same message that, our patients with autoimmune hypothyroidism have a much higher, risk and percentage of experiencing depression and anxiety.
Mhm. Mhm. And I'm sure a lot of them were diagnosed first with depression, maybe tried on antidepressant medication and maybe it worked a little bit, but if it's not what we always talk about, the root cause, right? If the underlying driver of their symptoms is hypothyroidism, it's important to uncover and address that. Yeah.
Absolutely. Yeah, I think that's a really common story that I hear in clinic. So patients
Mhm.
will come in and they'll be like, like I've been on this thyroid medication for 5, 10, sometimes 15, 20 years. I still like, I'm tired. My mood isn't great. And, the next step in the conventional care system is often offering them an antidepressant.
Mhm.
And some of these, some of the patients will try it and they're like, I don't feel any different. And a lot of my other patients will be like, I know I don't feel depressed. I know that that's not what's going on here. Like it
Mhm.
is something else. I intuitively know that, there's an underlying reason why I feel this way. And that's, where they meet me and where we look deeper and we try to uncover what's really going on.
Mhm.
So as far as, doing that, I mentioned kind of a proper assessment of the thyroid. I mean, that's often where I'm meeting people and starting their journey. And it's so important to do a thorough assessment and not only do the proper testing, but interpret them,
Mhm.
appropriately as well. So you mentioned hypothyroidism and hyperthyroidism. Hypothyroidism is certainly the more common of the two. So in hypothyroidism, essentially we're talking about low thyroid function or low production of thyroid hormones. So a lot of those symptoms are on the, slow, low mood, feeling.
Mhm.
You said, apathy, weight gain, constipation, like all of this kind of
Mhm.
slowing down of your, metabolic rate overall.
Mhm.
Hyperthyroidism is essentially the opposite of that. So where we see an overproduction of thyroid hormone. So patients with hyperthyroidism all often have, very stimulating symptoms. So, they might notice that their heart's racing or beating faster than it usually would. They may notice anxiety or insomnia and trouble sleeping, weight loss or loose stool, or diarrhea, sweating a lot. These are some of the things that, sometimes we see on the hyperthyroid side of things.
Mhm.
So
Which
when we're
sounds
look,
awesome, but is not.
yeah,
Yeah.
either side is really not great.
No.
I mean, there's really that sweet spot right in the middle, where
Mhm.
we're hoping that, we can get most people. So as far
Mhm.
as, doing that initial assessment, we do want to look at testing of, doing a full thyroid panel. So
Mhm.
not just testing our TSH or our thyroid stimulating hormone. This is generally, the main screening hormone that's run through our GPs, MDs, nurse practitioners. And the general approach is that, if we test TSH and it falls within a normal lab range, then we're good, we're done. no other testing or assessment needs to be done. Your thyroid is good, and, carry on. And I think that when we approach it in that way, a lot of people are falling through the cracks, and we're missing a huge percentage of people that could benefit from additional thyroid support or care.
Mm-hmm. 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 Yeah, like that's a question I have just even clinically for my own practice is, so it's hard to know when someone comes in with depression. Like my starting point is that it could be a variety of different things. I imagine, and I'm not sure in your clinic if people are coming in who either highly suspect a thyroid issue or know that maybe they're already taking thyroid medication, they've already been diagnosed in some way. But for me, I'll do basic blood work, let's say, and we'll test TSH. And it's hard to know if it's worth diving down the rabbit hole of a full thyroid panel first off the bat. Yeah. And so I'm curious about that, the TSH, so thyroid stimulating hormone, as a screening tool. How, if somebody's TSH is, and so as NDs, we have a little bit more strict ranges that we want to see. You have the Life Labs ranges that are like, TSH might be like what, 0.05,
0.35 to like 4.35, like somewhere in, the 0.5 to 4 is kind of for most labs where their TSH ranges.
Yeah. And then we as NDs are more like, I've heard things like under 2.5 is a little bit more ideal. And maybe you can speak more to that in a second.
Yeah, definitely.
But when you see someone whose TSH is sort of like 1 or 1.5, so this would be within the naturopathic ideal range, as a screening tool, is there, I'm sure there is benefit to dig a little bit deeper, but at what point could a clinician say, maybe we don't need to do the $90 thyroid panel? Yeah.
Yeah, totally. Yeah. And I think it's definitely part of that, clinical assessment, and having, in the questions that you're asking, and not just around, is it a thyroid issue, but is there other things that, you're suspecting are contributing to, depression or low mood. And we often, as a clinician, we're kind of going through our hierarchy, right? Okay, what's most common here? What are the things we want to rule out right away? And what are the things that, we need to screen through blood work for? So I would say my screening bare minimum thyroid testing includes TSH, which you mentioned, and then also includes thyroid antibodies. So that is like my bare minimum thyroid panel. And I really think that this needs to be adopted as like our thyroid screening panel. So I'll speak first to TSH, and then I'll chat about why the antibodies are so important. But like you said, TSH, we do like to see it in a bit of a more of a narrow range. So when we're seeing it, creep up over that 2.5, we do see it being related or linked to more cases of mood or low mood and depression. And we see that reflected in the literature as well. So as TSH goes up, we see higher rates of depression or more severe depression. So I think that upper limit of 2.5 is probably our best, marker of TSH for multiple levels: mood, fertility, TSH management overall, energy. In other countries and associations have adopted, this TSH marker of 2.5. I think that, we're a little lagging as far as updating our lab reference ranges for TSH.
And other markers, but yes.
Yeah. Definitely. And we won't go down that rabbit hole, because I'm sure we could do a whole other podcast on that. But yeah, a ton of different markers that, which is why that interpretation of the lab work is so important, right? We're not just relying on the lab to tell us, okay, this is normal. We're all good. We're really going through number by number and doing a more in-depth assessment and interpretation. if let's say your TSH was 1 and you were like, okay, like, this patient has depression, should we look in, deeper, then I would consider potentially some other thyroid markers may be worth testing. So I mentioned the antibodies. So thyroid antibodies, if you're not familiar with those, there are 2 of them, thyroid peroxidase antibodies and thyroglobulin antibodies. They're $10 each to test. So they're really like cost effective, worthwhile tests to do. And if the antibodies are positive, that's essentially, telling us that there's an autoimmune process going on against the thyroid gland. There's inflammation affecting the thyroid tissue, and over time that can lead to low thyroid function. There's 2 important things about the presence of antibodies. One is that they can cause their own symptoms. So even if your TSH is 1, the presence of those antibodies can cause symptoms of anxiety and low mood and fatigue and swelling and right? Like they're telling us that there's some inflammation in the body, and that chronic inflammation can cause, like as you know, and as you talk about with your patients, I'm sure the chronic inflammation can cause, its own long list of symptoms. So I think that's a really important piece of the testing the antibodies, is that they can cause their own symptoms. And then the second piece is that they can, if left unaddressed, can lead to hypothyroidism down the road. So the sooner that we can, test and address positive antibodies, we're really, working preventatively with our patients to prevent them from, becoming hypothyroid down the road. And we're preserving as much functional, healthy thyroid tissue as possible. Which is great. Who doesn't want that?
Yeah, exactly. And this is really interesting because this is our whole idea of like preventative medicine. And it's rarely, even someone who's diagnosed with hypothyroidism, I rarely see their antibodies tested by their conventional practitioner. 100%. Usually it'll be TSH and then T4, which we'll talk about. And, and so I always will ask, because it makes a difference from a naturopathic perspective in terms of treatment and how we might approach it. But yeah, and even just to see, somebody's antibodies start developing or increasing before their TSH changes or any other thyroid marker. So maybe years before they're diagnosed with hypothyroidism.
Absolutely.
And yeah. And this is like, I think common in a lot of the patients that we see in general is this feeling of not feeling like yourself, not feeling well, and yet your blood work is, quote, normal. And I always hear this in functional medicine, like WNL, so within normal limits, is also code for we're not looking. So are there antithyroid antibodies below the surface that we've never checked? And and I've certainly seen it. And I've seen the opposite. I've seen that antibodies are low, and then we know it's not. Absolutely. That's not what's happening. And maybe, people have heard of antibodies, I'm sure, from COVID, but
totally. Yes.
They're immune markers that attack, either like a virus or a bacteria or a foreign invader that can sometimes turn on our own tissues. In this case, we're making antibodies that are directing the immune system against the thyroid.
Yes.
And over time that causes damage to the thyroid tissue, and then it can cause hypothyroidism. And the most common cause of hypothyroidism is this Hashimoto's.
Yes.
Yeah. And so, and that is what you mentioned is part of your story, that your TSH was normal, all of your thyroid markers were normal, no diagnosis, but then you had elevated antithyroid antibodies. My mom, one of my best friends, same thing.
Yeah, it's very, very common. Like you said, Hashimoto's is the most common cause of hypothyroidism, like 95%, especially in women. And, we see it being more prevalent as far as, being diagnosed around often hormonal changes. So that's, often around pregnancy or postpartum or menopause. But you're right, like these antibodies have often been lurking in the background for, 5, 7, like sometimes 10 years.
Mhm.
And in my case, what you said, as far as I found the thyroid antibodies, and at that time, my TSH was totally normal. So I was like, okay, like not too worried about it. Like we'll just track it over time, see what happens. Over the course of, probably a year or two, my antibodies continued to go up, and so did my TSH.
Mm.
And then after a year or two, I was like, okay, I got to get serious about this because it's not looking good.
Right.
So then I started to incorporate more, directed treatment at my antibody levels and keeping my TSH in a more optimal range. And fortunately, I've been able to manage it, for the last 6 years. I had a healthy pregnancy. I had, my son, very healthy postpartum. And I think that a lot of that is because I was able to find it early and work preventatively with it.
Mhm.
And I'm so grateful that I was able to do that. And I had the knowledge to do that for myself. But there are so many patients that don't, right? And they experience things like depression, like fatigue, like miscarriages, like
Mhm.
postpartum thyroiditis and anxiety, without ever knowing that, that it's really been an underlying thyroid issue the whole
Mhm.
time. And I think that is, the bigger mission for me, and the bigger message is getting that full assessment, and hopefully preventing as many women as possible from going through that experience.
Yeah, and just increasing awareness so people even know to ask for this and advocate for this.
100%.
It's
Yeah.
10 bucks, like not that
Yeah.
big a deal for
It
anyone.
is
Yeah.
literally like, it's
Yeah.
easy. It's an easy test to do.
Mhm.
So yeah, I think that's definitely worth asking your practitioner about, worth reading about, and worth looking at for sure.
Mhm.
Yeah.
And I think one thing I see a lot is patients that have one autoimmune condition. So maybe celiac or
Mm.
maybe like a family history of rheumatoid arthritis. And a lot of their autoimmune markers are low, but they have these kind of general like autoimmune type symptoms, inflammatory symptoms. A lot of the time, they'll have elevated anti-thyroid antibodies. And I've heard it expressed like this. I don't know if you agree, but like the thyroid is our canary in the coal mine, like a sensitive tissue, and often is sort of the first to exhibit an autoimmune pattern. Um, yeah.
Yeah, I would agree with that. I think that, when we see patients with multiple autoimmune conditions, or maybe just this general low level kind of inflammatory state, we can often pick up thyroid antibodies as one of the first markers of that.
Right.
And I do see that clinically a lot. And sometimes I'm kind of putting my patients in two different piles. One is like this very clear hypothyroid, you have Hashimoto's, you have, very high thyroid antibodies, it is thyroid specific. And there are other patients that I'm like, we're picking up thyroid antibodies. I'm not sure how clinically, relevant it is from a thyroid perspective. I think it's indicative of this larger inflammatory story.
Uh-huh.
So that is often how, I'm seeing sometimes these two different pathways in my practice anyways. And often I'm working with them on more of a general inflammatory, autoimmune plan versus something that's very specific to the thyroid and very targeted. Does that make sense?
Yeah, definitely.
Yeah.
Because even as you're
Yeah.
talking, I'm thinking there's a pattern that I've noticed, and it's hard to know, like, is it chicken egg? Is it this
Yes.
more like insulin resistance? So I see like an insulin resistance, fatty liver, and hypothyroidism pattern.
Yeah.
And from what I've read in the literature, it can be like thyroid making someone more susceptible to, lower metabolic rate, more susceptible to insulin resistance, and fatty liver, and then the opposite, where
Yeah.
fatty liver can start to create a more inflammatory state and affect thyroid function. And so I see that a lot, and it's hard to know, like, where do you start with that? But that makes sense when you're putting them, okay, where this person, we're looking more at like general inflammation and trying to bring that down, and it's going to benefit your thyroid.
Yeah.
And then the other camp, this is where we need to we need to start here. This is the main driver of your symptoms is this hypothyroid state.
Is the thyroid.
Mhm.
Yeah.
Yeah. But I mean, our thyroid, like you said, is the orchestrator of all these different systems. So it affects our fertility. So it's like our ovarian health. It affects our, like, there's the adrenal sort of like, stress and burnout and those kind of symptoms. And then there's this like metabolic arena in which it can affect. So it has its hand in every pot.
Yes. Yeah, it absolutely does. And I think this is where, we have to put on our thinking caps as a clinician and try to kind of unravel what's going on an individual basis for every one of our patients. And by talking to them and understanding their story, have a better idea of what is that thread that we need to pull on first, right? Is it the thyroid? Is it a picture of chronic stress? Is it infections and chronic infections? Is it, trauma? Is it, going through all of, and that history taking is so important because it allows us to really have a better idea of where we need to start. And in my practice, absolutely, I would say, most of the patients that come through my doors have a diagnosed thyroid issue. This is an area that we're often focusing on first. But I think that most patients that walk through any of our doors can often benefit from some sort of supportive thyroid care, but it may be down the list as far as our hierarchy and where we want to be, focusing our energy, because we can't do everything at once.
Right.
And we need to, start somewhere for sure.
Yeah. Like, is the patient with fatty liver, like, is a thyroid supplement, which we'll talk about those like thyroid supplements, but is,
Totally.
giving them like, a thyroid supplement, going to have the biggest, if we want to stick to like a max 5 supplement plan, is that going to have the biggest leverage in helping them, gain functioning and heal? It's like, maybe not, right? Maybe we need to focus more liver and insulin resistance and lowering inflammation, but maybe that is a massive driver. So maybe
this is the challenges of medicine, right?
the art of medicine.
Exactly. Yeah.
Maybe we'll talk. So when someone goes to their conventional doctor, and then these are many of the patients that walk into your office, they've been diagnosed with a thyroid condition, hypothyroidism, maybe. I think it's probably the more common one.
Absolutely.
So what happens to them? So they're often screened with TSH, and then what's typical for many of these patients in terms of further testing that they get from their conventional doctor and then treatment? Maybe we could speak to that. And then,
So just on the conventional side of things?
Yeah, because that's usually where people start, right? Like, they usually don't see an ND first.
Typically.
Hopefully that will change. I don't know.
Down the road. So typically people see their GP or family doctor first. That TSH is done. If the TSH is elevated, sometimes we're looking at a watch and wait scenario where people aren't even offered treatment initially. They're okay, maybe their TSH is 4 or 5, and we're saying, okay, your free hormones are normal, your free T4, your free T3. This is a case of subclinical hypothyroidism. Maybe we don't need to medicate you right away. We'll kind of watch and wait and see what happens over, the next year or two. There are other people where their TSH are, or is very elevated, 20, 40, 60. Like, I've seen some really high TSH levels. And these people are generally given a medication right away. So the most common medication that we give for hypothyroidism is levothyroxine. So it's a synthetic T4 or that T4 hormone, and that acts in our body, produces or is converted to the active thyroid hormone, which is our T3. And it's the T3 that is the hormone that actually goes into all of our cells to create all those positive changes that we talked about before.
And so maybe we'll just jump in really quickly, because when we're talking about like elevated TSH, and this was maybe this is the reason that you're like, I don't want to study thyroid, because it's like a counterintuitive for a lot of patients. But TSH is when it's high, it means hypothyroidism. Maybe just quickly like why that is.
For sure.
Yeah.
Yeah. So it's a little bit opposite as far as the TSH goes. But TSH is actually a hormone that our brain produces. So it's not actually a thyroid hormone. It comes from our pituitary gland in our brain. And we can think about the TSH as a bit of like a whip almost, as far as if our body or our thyroid is not producing enough thyroid hormones, then our TSH starts to go up. It starts to yell at our thyroid gland. And if we're still not producing enough thyroid hormones, that yelling gets louder and louder and louder. So in hypothyroid, where we're not producing enough thyroid hormones, our TSH is high. And in hyperthyroidism, where we're producing too much thyroid hormone, our TSH actually comes back very low or suppressed.
Yeah, perfect. So yeah, when someone's
Yeah.
TSH is like 4, a little bit out of range, it's like there's a low level.
Yeah, we're
Like,
just kind of yelling a little bit, right? We're just
yeah,
a little impatient, a little irritable.
yeah, you're like,
If
I
it's
gotta,
like
yeah,
10, we're like,
yeah,
yo, man, like, let's get to it. Start making more thyroid hormones.
exactly.
And when it's 40 or 60, we're screaming,
Yeah.
right? Like there's nothing happening there.
Yeah,
Yeah.
super high. And I think like when you mentioned the watch and wait, this, I think I see a lot of patients frustrated by this.
Yeah.
And as NDs, right, we're thinking in the realm of functioning and optimal functioning.
Yeah.
And so not necessarily like, do you have a disease or not, right? That's not necessarily our differentiation. Like we want to help somebody feel as best they can. So, but what I'll often say to people, because the conventional treatment is Synthroid, is levothyroxine, it's a
Yeah.
lifelong medication. You take it like 2 hours away from food. It's something that you take forever. So when that's the only tool that someone's wielding, often we're careful with it. If someone's TSH is slightly elevated, the prescribing physician might think like, well, maybe this is temporary, transient, and do I want to put this person on a lifelong medication if it might go back to normal in a few months, right?
Yeah.
Although this is frustrating for patients because they're like, well, I want to feel better. I want there to be a solution, and I want you to tell me what's wrong with me. So maybe we can move to, okay, what would an ND do? And then also,
Yeah.
and I'm sure you see many patients like this, they're on Synthroid. So they've been diagnosed with hypothyroidism. They've been prescribed Synthroid. They're taking it every day. And yet they
Yeah.
still don't feel optimal. So there's this
Right.
treatment gap that can happen. So there's like a couple of scenarios, I think, that
Yeah.
are pretty common for people. Yeah.
Yeah. Yeah, so I think in that like first scenario that you mentioned where we're seeing kind of like a borderline TSH, again, like it for me, it comes down to further assessment. So if someone came into my office like that, okay, my TSH is 5, I haven't started medication yet, like, what do we do next? And I keep coming back to thyroid antibodies, but obviously that would be like, the next step in assessment as far as finding out if they have positive antibodies. Because if they do have thyroid antibodies, this is generally not something that's going to get better as time goes on, right? So there is no point waiting a year or 6 months to, start treatment or, do things like that, because if we don't address it, it's just going to get worse over time. So I think that is a huge percentage of people that are maybe told to, wait it out or see if it changes, but aren't having their antibodies assessed and aren't taking into consideration that autoimmune process and how this disease progresses over time. So that's
It's not
definitely
like,
one.
oh, you just kind of have low iron, like it's like,
Right.
which I sometimes see.
100%.
Like there's something driving this and it's going to get
Yes.
worse if we leave it. Yeah.
Yes. I think the more challenging one for often us as practitioners is if that antibodies are actually totally within normal. Then we're like, okay, now what do we do with this patient? And you mentioned some really good other, tests that I'm often looking at. So as part of, that complete blood work, looking at iron levels and seeing if people are low iron, that in itself can lead to, increases in TSH. Vitamin D is another one that can impact TSH levels. levels. So, doing some nutrient testing and see if we're missing some building blocks, essentially, for thyroid hormones. We often also see the impact of other hormones on our thyroid hormone production. So cortisol can impact TSH levels. Estrogen can impact TSH levels as far as, typically oral estrogen or added estrogen that we're taking as a form of medication. So these are all things that, what's that?
Or like birth control, could that?
Yep,
Yeah.
for sure. Yeah, any oral estrogen can definitely impact our thyroid hormone. So these are other things that we would want to take into account and consider for people who have an abnormal TSH, where maybe their antibodies are not abnormal or are not elevated.
Yeah, I see the iron one a lot in practice. Like someone's ferritin, which is iron storage, will be low, and their TSH will be like usually more typically in the 3s. So not out of range, but still not great.
Yeah.
And so then we're always like, well, is this like, do we go thyroid? Is that the driver? But what I've found pretty much every time, as long as there's no antithyroid antibodies, is that like, once their ferritin comes back into a more normal or more optimal number, then TSH comes right down to the 1s or low 2s.
And that's brilliant, right? Like, what an easy solution. Like, those are not people who we want to give a thyroid medication and have them on a thyroid medication for the rest of their life. Like, it's completely unnecessary. So if we can treat it from a nutrient point of view, or other things that are impacting the thyroid, then I mean, that's what a gift to those people and those patients.
Yeah. And then with that other scenario where somebody's like, okay, they went to their MD, their TSH was like 10. MD's like, okay, here's a new medication for you. It's a tiny little pill. You take it every morning before food. Set your alarm and wait an hour before coffee.
More importantly.
It's a horrible. Yeah.
Yeah.
And then they're like, okay, I don't know, maybe I feel a little bit better. Maybe not, and maybe I feel a little bit better, but there's still a big gap in how I feel. And could this still be my thyroid, or is the thyroid treated? And so
so again, like, if a patient like that is coming into my office, I'm like sounding like a broken record here, but like assessment, right? So in those patients, I am looking at a TSH. I'm looking at their free hormones as well, T4 and T3. We're looking at thyroid antibodies. Maybe they haven't been tested, maybe they've been missed, and then looking at those nutritional markers as well. So my big 3 are iron, B12, and vitamin D. So doing that allows us to take a look at a couple different things. One is the thyroid hormones themselves. Are they truly looking optimal to our eyes on blood work? Is their medication being dosed appropriately, where their TSH is landing in that optimal range where we want to see it, between 1 and 2 is really what we want to aim for. 2.5 at the very high end if someone is on a thyroid medication, in my opinion. And then their T4 and their T3. So we also want to see these hormones in adequate ranges. So our T4 is typically in the mid range, anywhere from 12 to 16 if people are on a thyroid medication like levothyroxine or Synthroid, which is T4 based. And then we also want to see our free T3, I would say, in from the mid to high range. So anywhere from 3.5 to 5.5. It's a bit of a larger range with the free T3, because it is a bit of a it's a test that there's a lot of variation with. So I give it a little bit of a larger gap. But sometimes what we see in patients is that their TSH is normal. It's great, even to my eyes, in an optimal range. Their T4 is great. They're on a T4 medication, makes sense. But their T3 is like really lagging behind. So it might be like 2.5, and it is coming up low when we're testing it on their blood work. And in this situation, it makes sense that they would still be experiencing chronic symptoms of hypothyroidism, because that level of actual active thyroid hormone, the one that is actually doing all the work, is low. And so in those people, we see it being a conversion issue. So that's kind of like the word on the street as far as, in functional medicine and naturopathic medicine, we talk about conversion a lot. So, in these people, we see that there's a challenge converting their thyroid medication or that synthetic T4 into that active T3. So we either need to, look at ways that we can support that, naturally in their body, to support, them taking in this T4 medication, converting it to T3, or we can also look at different types of medication that have T3 already built into it. So there's less burden on the body to do some of that converting or conversion work.
Yeah, because this is, so we can like get that conversion happening. There's some nutrients and some obstacles, like is cortisol an obstacle to that conversion? And
so like so many things can affect the proper conversion into T3 or the enzyme that does that work. So there are certain nutrients, so that specific enzyme is selenium dependent. So selenium, can be an important cofactor in making sure conversion happens. A lot of the conversion happens in our liver. So if there's, fatty liver, if there's insulin resistance, that can definitely impact how well our body is able to do this conversion. If there's chronic inflammation, if there's high cortisol. So like you see, like when I'm talking, right, we're like, this is like 99% of our patients have at least one of these barriers that's going to impact potentially this proper conversion from happening. So at times, integrating T3 into their medication is sometimes the most successful way that we can achieve, this as close to symptom free as possible.
Yeah, because when we were even talking before about that, the fatty liver, like hypothyroid connection, somebody gets put on medication and they're like, well, maybe this will help my insulin resistance fatty liver, but no, because part of the condition is the issue with conversion. So maybe either working with that conversion or something like a desiccated, which we can get into, that has T3, so kind of skips that step and allows the whole, like all the gears to start moving properly.
Yes, exactly.
So we NDs are able to prescribe desiccated, and maybe and that can be maybe somebody's only medication. Like if they decide to do that in lieu of Synthroid. I've also topped people up with desiccated who are already on Synthroid. Like we might do a little bit to just get their levels in a more optimal range if their GP is not willing necessarily to like increase their Synthroid dose. But yeah, maybe let's talk about what's desiccated thyroid.
So desiccated thyroid is another form of medication, a thyroid medication out there. We consider it to be a combination thyroid medication because it contains both T4 and T3. So we're having both of those thyroid hormones in it. It is sourced from porcine or pork thyroids. So that's where, we're getting the hormones derived from. So in a lot of cases, this is why it might be called like a natural desiccated thyroid versus a synthetic, T4. Because it's sourced from a gland itself, it also contains some of these less active thyroid hormones like T2 and T1 that, don't get a lot of press. We don't talk about them a lot. And I'm not sure, exactly how beneficial those hormones are, as like we don't really have a good understanding of them clinically, but we are getting a full spectrum of thyroid hormones when we're opting for a desiccated thyroid instead of a Synthroid or levothyroxine. So like you said, it can be used on its own instead of Synthroid, and you can combine them as well. There's no issue in doing that and giving people a little bit of that, T3, which is sometimes a game changer for a lot of people.
Yeah, it's interesting, like the T1, T2 thing, because I'm sure people are wondering, we're like, you're talking about T3 and 4. What happened to 1 and 2?
Yeah, where's 1 and 2?
What happened to those? And I wonder if it's kind of like a plant. We don't understand what those compounds do, but they may communicate or produce some sort of synergistic, like some overall holistic sort of benefit, but who knows? And one thing I remember from your course that I'll never forget, Katie, is this idea, because I always thought that When somebody had Hashimoto's picture, so elevated anti-thyroid or thyroid antibodies, that we had to address the immune system, and that thyroid replacement, so either like a synthroid or desiccated, wasn't going to treat it. But then what I learned from your course is that desiccated and synthroid both can reduce antibodies, which I think was really important for me to understand, because
Yeah.
I always thought like I have to address the immune system. I have to go after antibody reduction to fix this or to help this person heal. But actually supporting thyroid hormone production via a medication
Mhm.
is a way to do that as well. Yeah, maybe you could speak to that. Like,
Yeah,
yeah,
absolutely. And I would say like it's one of our tools, right? I don't
yeah,
like, let's not only use Synthroid to address it, because I think that's, what happens in a lot of cases, and where a lot of people tend to still, be experiencing chronic symptoms, but
Mhm.
it can be a really valuable tool. So, when there's this chronic inflammatory state on the thyroid gland, taking a thyroid medication, what I say to people is like, kind of like just lets the thyroid chill out and relax a little bit. Like it brings down the inflammation. It can bring down thyroid antibodies by allowing that, burden or that pressure to decrease that's on the thyroid gland. So, whether we're using synthroid or desiccated thyroid, both of these DSH into a more low normal range. And in that way, okay.
Anyways, we had a bit of a
Yeah.
connection issue. Yeah.
So when we take a thyroid medication like Synthroid or levothyroxine or desiccated thyroid, it does help to alleviate some of the stress and the inflammation that's affecting the thyroid gland, keeping that TSH in a low normal range. And that often results in a lowering of our thyroid antibodies just all on its own. But we absolutely do want to combine it with, those things that you mentioned as far as addressing the inflammation and the autoimmunity. And I think using both of those is where we really get some like dynamite results for our patients.
Yeah, that's so great. Yeah, that was such a good thing for me to learn, because and it makes complete sense when you're giving the thyroid just you think of like the antibodies are attacking it, it's struggling to produce thyroid hormone and it's working really
Yeah.
hard. If you just take a
Yeah.
bit of the burden off of it, you give it
Yeah.
a bit of a chance to chill and to heal the tissues that are inflamed, and you can see that. Yeah.
Absolutely. And while we do this underlying work as far as reducing the antibodies, and especially if it's something that we catch early enough, a lot of my patients are able to take a thyroid medication for, maybe a year or 2 years, and then we're able to decrease their dose and come off of it because the
Mm.
thyroid gland has, been able to take that break and to heal, and we've addressed the inflammation, and they're able to, come off of their medication entirely. So I think sometimes this whole messaging of like, oh, once you start it, you can never come off of it, is not always the case. It really is patient specific.
Yeah, I found that personally. I was on desiccated for a while, and then
Yeah.
I came off, and everything kind of went back, like kept in the optimal range, which was really great.
Amazing.
So I didn't have to wait an hour before starting my coffee in the morning.
Painful, right? Yeah. Yeah.
Um, and so, maybe we'll get into some nutrients, because people have heard of iodine, and that is something that's a little bit,
Yeah.
that's in a lot of these sort of thyroid combo supplements, like, these supplements that are marketed to support thyroid function. People hear of iodine, a lot of patients ask about it. Why is that not the whole story? Like, what are some nutrients that people should consider that you normally work with? Like, we talked about ferret, like iron, we talked about
Yeah.
D. Mhm.
Yeah, I'll definitely speak to like the iodine and thyroid support complexes. I feel like I'm always like a little bit on like a soapbox about these topics. So you can cut me off at any time.
No.
So the thyroid support complexes, like, I think in theory, like, it's a great idea. It's a great concept, right? We'll just give the thyroid all of these, ingredients, backbone ingredients that it needs to produce thyroid hormones. So for those of you who don't know, so our thyroid hormones are made up of iodine and tyrosine as well. So those are two hormones, or two ingredients or nutrients that our body uses to make thyroid hormones. So I think, in a very A equals B simplistic view, it would make sense to give our body more of these nutrients, and our body would just naturally make more thyroid hormones. Unfortunately, that's not how it often works in the vast majority of cases. So I don't know what your experience has been with thyroid support complexes. In the first couple of years of practice, I used them a lot. And then I was like, man, these do not work very well. Like, very rarely did I see like significant improvement with them. And I think that a big reason is because of, it's only providing those backbone ingredients to the thyroid gland. And if a thyroid is, inflamed, if it's stressed out, we can give it a dump truck full of iodine or a dump truck full of tyrosine, and it's not necessarily going to be able to make thyroid hormones, even in the best case scenario. So the more important thing is to address the inflammation and those thyroid antibodies. And that's the way that we're going to get the most significant results for our patients. I don't even carry a thyroid support complex anymore, like, in my clinic. And that says a lot, because I see like only thyroid patients, right? So I really, like, once I changed, the way that I approach thyroid conditions, like, that's when I really started to see more benefits for my patients. And iodine is a really tricky one as well, because, we see a lot of different opinions around iodine. Take iodine, don't take iodine. Some practitioners are recommending very high doses of iodine. Specifically when it comes to Hashimoto's disease and what we see in the literature, it's very clear that excess or added iodine is actually detrimental to this disease process. What we see is that it acts as a pro-oxidant, or causing more inflammatory stress on the thyroid gland, and can actually trigger cases of Hashimoto's or Graves' hypothyroidism disease. So we really need to be cautious around iodine intake in our thyroid patients if they have those positive antibodies, or if we don't know their antibody status. So, if you're someone out there listening who, maybe your TSH is a little above normal, and you don't know your antibody status, you've never had them tested, don't go out and buy a thyroid support complex that has added iodine into it, because that may be actually something that's going to worsen your condition or disease in the long term without you even knowing.
Thank you. Yeah. I think, like, what my thing with iodine, so there are certain conditions like fibrocystic breasts and breast tenderness and things like that it's indicated for, but I'm always like, how do I balance a potential deficiency with then, this potential to harm with excess iodine? And I think I don't know if you have any, but I don't know any good ways to, and patients will ask, how do I know if I'm getting enough iodine or red iodine? And because we do need iodine, and it's unclear, like, if it's a common deficiency and how to test for that deficiency. I don't have a good way of doing it. And I guess just getting it from diet might be a safe way to ensure someone's getting some iodine without overdoing it.
Yeah. It is like, so it is a bit of one of those Goldilocks nutrients, right? Or something that
Totally.
has what we call, a very narrow therapeutic index. So the
Mhm.
sweet spot for iodine intake is very narrow. We don't necessarily want no iodine at all, because it is important for things, like breast health and thyroid health.
Mhm.
And during pregnancy, we need to have iodine in our prenatal because baby needs it for brain development. Like, there's some really important roles that iodine plays. But on the flip side, once we toe the line into iodine excess, then we're also potentially creating more issues. So, that range can be really, really narrow. We're talking like, 100 micrograms can make a
Right.
difference, which is very easy to get, from a dietary standpoint. So I think most of us are probably getting our iodine needs met from our diet.
Mhm. Mhm.
In the vast majority of people. So a lot of our iodine content comes from dairy, eggs,
Mhm.
commercial breads have iodine in them, iodized table salt. Like, that's something that we're finding in a lot of foods. If you're eating out, in processed foods, or using added salt, or if you're using iodized table salt at home. Fish and seafood have lots of iodine in them. Certainly, if you're having any seaweed based
Mhm.
foods, those definitely have lots of iodine in them. The little like seaweed snacks, or just going out for sushi, having, any algae based things. So these are all things to consider that would be contributing to your iodine intake, but also things that I talk about, with a lot of my patients, as far as making sure that they're not having too much of those things.
Right.
So I talk about the 3 S's. So supplements. So looking at, thyroid support complexes that have, potentially added iodine in them, multivitamins that have, sometimes more iodine than we want our thyroid patients to be on. And sometimes superfoods like greens powders and things like that will have algae-based powders like chlorella, that have a lot of iodine just naturally in them, that I may want my patients to avoid. So supplements is a good one to think about. Salt, we talked about iodized salt. So if you're someone that should be having less iodine, switching to a kosher salt,
Mhm.
or even a Himalayan or a sea salt has less iodine than an iodized table salt.
Mhm.
Um, and then the seaweeds. So sushi, seaweed, salad, seaweed snacks, algae-based superfoods, things like that. So those are the 3, I think, sources that we can get almost in trouble with if we're having a lot of those things in our diet.
Mhm. Yeah, if we're like just, pounding back the
Just
greens powder.
crushing seaweed snacks or
Oh my
chlorella
gosh.
powders, then yeah, it
That's
could be an issue for sure. Yeah.
so I'm
Yeah.
laughing because I would like just it's like cracked me those things, but I don't know. I always thought, well, maybe it means I need iron. It's hard to, but it's also they're also very salty, so it could just be an addiction.
Salt
Just yeah,
craving. Yeah.
exactly.
And you're right, like testing iodine is a real challenge. There really is not a good, accurate way of testing iodine levels. So that becomes a challenge too when, we want that objective marker. We want, to assess our patients for iodine levels. We
Mhm.
don't have a really good way of doing that,
Yeah,
unfortunately.
yeah, it's
Yeah.
hard. Like it's always yeah, like a Goldilocks vitamin is a perfect way of describing it.
Yeah.
Then one thing, yeah, I think you asked, do I use the so I'll also say this because just in case patients are listening, we're like, hey, I got put on a thyroid multi.
Totally.
Well,
Yes. And sometimes that is what we want to do. Yeah.
yeah, I think for there is one product I'm thinking of that has tyrosine and ashwagandha and selenium, um, a little bit of iodine, not a terrible amount, but I think I'll not really just for thyroid, but sometimes I give that supplement for it's more for the ingredients. So sometimes for like some adrenal support, some energy
Yeah.
support, and a lot of the time for fertility, because selenium, iodine, um those can also be helpful for ovarian health. So there's like the tissues, it's interesting because they like our thyroid tissue, our ovaries, our adrenal glands themselves
Yes.
require similar nutrients, mitochondrial support, um dopamine. So dopamine's a hormone in the brain, or a neurochemical in the brain that is also based on tyrosine, just like thyroid
Mhm.
hormones.
Mhm.
So there's often like sometimes when we're trying to minimize the supplements to give someone, that could be beneficial. But you're right, like to be more specific when we know specifically what someone's dealing with, especially when it's more of a, like those multi sort of thyroid products are not indicated for the more Hashimoto's like picture, in my opinion, like not for elevated thyroid
I would
antibody.
definitely echo that sentiment. So yeah,
Mhm.
the thyroid support complexes I'm not using in a Hashimoto's picture, which, as we talked about, is the vast majority of people with hypothyroidism. So I think we, not just patients who are, maybe looking for solutions and shopping at health food stores, but, practitioners as well, we need to rethink some of our tools and how we're addressing some of these conditions.
Yeah. And I think the tricky thing, and one of the things that one of the conflicts we face, even in the reputation of our profession, is that, like we mentioned, hypothyroidism can encompass like every symptom that somebody might struggle with, like a typical person would struggle with. And then you go to the health food store, so you Google it and you find, okay, well, my hair loss and my puffiness and my brain fog and my regular periods or dry skin, and then you go to the health food store and you see thyroid, and so like, okay, let me take this. And that's, we're often like missing the mark, the assessment and the understanding of what's going on and how to actually address it in a meaningful way. So yeah, that's, I think, an obstacle that I'm sure, it's a trap I think many patients have fallen into, who are like trying to get their thyroid working with products that are marketed for thyroid but aren't really addressing what might be actually going on.
Exactly. Yeah. Especially when we get into that. Okay. Yes, it's a thyroid issue. It affects your thyroid, but Hashimoto's, when it all comes down to it, is an autoimmune issue. And I think that's where we need to focus most of our efforts and treatment options on. And all of the things that are actually successful in treating Hashimoto's are things that act on, decreasing inflammation, balancing our immune system, giving our body antioxidants. Those are the things that are really going to move the needle forward for our patients.
Like I know in one of your, I think it's an Instagram reel, I think.
Okay.
You mentioned inositol. And this is something
Yeah.
new to me. Yeah, maybe you can speak about that, because that is something that I have used for other conditions, but I have never thought about, and maybe I'm just behind on the research for this for thyroid conditions. So maybe what's inositol? How does it work? Obviously, we're not telling people just to go and get treatment. You need the assessment to know what treatment's indicated, but I think this is interesting. Yeah.
Yeah, inositol is like, I have a major love affair with it because it is beneficial for so many different areas of the body. And as a clinician, that's such a bonus when you can give one product and it can do so many things. Like, that's just, amazing for us. So it is like essentially almost like a B vitamin, like it's what type of nutrient it is. And it's like a carbohydrate based powder. That's often how we're prescribing it to our patients. A lot of people are more familiar with inositol and using it with things like PCOS, which is more of an ovarian condition, and irregular ovulation. So our ovaries, and the inositol is helpful for promoting regular ovulation. The research for inositol with Hashimoto's is actually really cool. So we see that giving, anywhere from 600 to 1200 milligrams of inositol a day can decrease our thyroid antibodies and can help to regulate our thyroid hormones, so improve our TSH levels. And at the how inositol works is essentially twofold as far as the thyroid's concerned. One, it acts as an anti-inflammatory to help decrease those thyroid antibodies, but it also acts in terms of the signaling pathways that our body uses to manage our TSH and our thyroid hormones. So when I started using inositol and integrating it into my treatment plans, like, it was a game changer. Like, it really makes a massive difference for, the level of reduction I'm seeing in thyroid antibodies and in TSH levels as well. So it's very cool. I love using it. It tastes like sugar, so like it's super easy for people to
Mhm.
take. And
It's a
then
low
if,
dose, just 600 to 1200, super
yeah,
low.
it is
Yeah.
a lower dose.
Mhm.
We're often using up to 4 grams in conditions like PCOS or insulin resistance, which, as we've kind of mentioned before, there's a lot of overlap between,
Mhm.
PCOS and hypothyroidism and insulin resistance and hypothyroidism. And then it also has mood benefits as well. So, there's tons of things that it can address all at once. I'm generally using it from the thyroid perspective, but yeah, it's one of my favorites.
It's
And it's
awesome.
one, like you said, that a lot of us are not necessarily aware of,
Mhm.
or classically been taught around the benefits of inositol and thyroid health. um, but when you get into the research and looking at the nutrients, that we do have a lot of high quality studies and evidence-based research behind, and inositol is absolutely one of them.
Yeah, it's so cool. Yeah, like it's also very high dose, like anywhere from 9 to 18 grams for like OCD or
Mm,
psychosis. And it's thought to like help serotonin fit better into receptors.
that's cool.
Yeah, which is interesting. Someone who
Wow.
might be on like an SSRI, like a selective serotonin reuptake inhibitor for OCD, may not be getting full benefit if their serotonin that they make doesn't fit
Mm,
into the receptors. So inositol can help to kind of like modulate as I think a
very
neuromodulator in
cool.
and of itself. So yeah, so there's a lot of overlap. If
Isn't
someone
it
has,
amazing?
yeah, like if you have
Oh,
PCOS, insulin resistance, and
yeah,
Hashimoto's and OCD, and those things can definitely coexist. It's like, well,
yeah,
here's a one size fits all, one thing for you to take.
yeah,
Tastes like
yeah.
sugar.
And
Yeah.
it's, yeah, it's just like a scoop of powdered sugar, in your water, and you're good to
Yeah,
go. So yeah,
totally.
it's pretty cool.
That's really cool. Yeah. And then there's some herbal medicine too, like ashwagandha for raising T4. And I don't know if you work with Romania for the autoimmune picture, but like, yeah, I mean, it's always tricky with herbs. They can be sometimes expensive,
Mhm.
sometimes don't. What would I say about herbs? I love herbal medicine, but I find that there's often a point at which the herbs have done their work, and we don't no longer get benefit anymore. Like sometimes I find that.
Yeah.
Um yeah, so yeah, is there like
Yeah. I
yeah.
mean, yeah, ashwagandha is probably the one we have the most research
Mhm.
for, around treating hypothyroidism, not necessarily Hashimoto's, but like you
Mhm.
said, increasing or boosting up that T4 production that the
Mhm.
thyroid is making. So I do like to sometimes incorporate that into, treatment care plans, especially, if we're dealing with cortisol dysregulation and chronic stress. Like I love ashwagandha for that as well. So it is certainly one of my more commonly prescribed herbs.
Mhm.
I'd say that is like really the biggest one that I use from a
Mhm.
thyroid perspective. When we get into some of these other herbals that I think are used, a lot traditionally, or have, some history as far as being used from a thyroid perspective, when I'm looking through like the research and things like that for these herbals, a lot of them are animal studies, like
Mhm.
in vitro studies, like very few, like maybe 2 or 3 in vitro or animal studies from like the 70s. Like there's really no updated research on some of these herbals,
Mhm.
where there is a ton of emerging research when it comes to things like inositol and selenium and vitamin D. So
Mhm.
those are always the things that I'm starting with and I'm seeing, obviously good results with. And then, if we need other supports, then maybe considering some herbals down the road. But you're totally right. The herbal route can be much more costly for
Mhm.
patients. So from a cost perspective, like a bottle of selenium is $14 and it
Right.
lasts you 2 months, right?
Mhm. Totally.
um,
Yeah.
so I'd rather, start there, from a cost perspective, but also, because of what the research is telling us, with my patients. For me,
Mhm.
anyways, that's how my practice has developed. Yeah.
Yeah. And I think like, and this also just speaks more to this idea of like when you're doing an assessment with someone, you're looking at the whole person, it's like, okay, well, this person is a great, like, well, their iron is low, so we want to support them. Like, it's not necessarily a top down protocol type thing. So when talking about treatment, especially on this podcast, I usually like to frame it as like, here's some possibilities, but obviously you want like a bottom up assessment for all these things to be taken together. And formulating a treatment plan, like, we're always taking into account the person in front of us in terms of like what they're capable of paying in terms of cost. And do you like swallowing pills? Do you not? Well, inositol is a powder, selenium's a tiny little pill. What's sort of the max amount of things you're willing to take? Like, try and keep it minimal, and so we're looking at like what makes the most sense if somebody's dealing with a lot of anxiety and cortisol issues, and their T4 could use a bit of a boost. Maybe ashwagandha is great for them.
Perfect, right?
Totally. But if it's more of a Hashimoto's issue, then probably not the number one herb unless it's prescribed for other reasons. So we're looking at somebody from this holistic perspective. And I guess I also want to ask about diet. Like, I'm sure people have heard gluten-free. So maybe.
Totally.
You're really like,
gluten-free.
Another soapbox. Let's get it off.
I know. Jeez Louise. So I mean, I have lots of thoughts around, diet. And I mean, I think the most important thing is that it does have to be individual, and it does have to be tailored for each and every patient, from, what foods make them feel good, what feels right for their body, their, emotional health around eating, or lack of emotional health around eating. These are conversations that we have to have with our patients. I do believe that, our diet and our food can make a huge impact on how we feel day to day. I think that in the thyroid world, there's a lot of fear-based messaging around certain types of food or certain categories of food. Gluten is one of them. We often see dairy being another one, where, some of the messaging that I'm seeing, even, on social media and things like that, is, if you are diagnosed with Hashimoto's, you can never have gluten again, never touch it. Like, it sets fire to your thyroid and it will never be the same. Like, some really scary stuff, right? And those are things that I have, read for years and years. And again, going into the research about what it is really telling us around gluten, and that for most people, these are not people who have celiac disease or, some sort of, autoimmune condition that where they cannot tolerate gluten. But for most people, they may be able to have gluten occasionally or continue to have it every day in their diet. Like, for me, it is not a game changer, or it's not a deal breaker that they have to eliminate any food from their diet in order to feel better with Hashimoto's. And I think that's, where maybe my message is different from some other practitioners who are like, no, in order to feel better, like, you have to make dietary changes. I think it can sometimes be helpful for patients if they're, ready and willing, and it's something that makes sense for them. But I don't like restricting people's diet and taking out whole food groups if we don't need to.
Yeah, this is good.
I don't know how you feel about it, because this can definitely be a very polarizing conversation, especially when we're talking with, naturopathic doctors, functional doctors, things like that. Like, people have some, fairly firm, sometimes beliefs around it. But
like, I know that, well, we talked, right, that there can be this comorbid, like, it's usually like, what I've seen is someone who has celiac can often be at risk for Hashimoto. So in that case, the person, like,
100%.
But just in the case of celiac in general, whether it's causing, whether it's connected to Hashimoto's or not, you have to, like, use bags for your gluten-free toast in the toaster. Like, you can't shop at Bulk Barn. Like, there's zero contamination, and maybe that person, we need to talk about being removing any cross contamination and being extremely strict, because with celiac there really can't be any
absolutely
gluten. And I agree with you. Like, I think the problem is with social media is that again, it's more of that top down, right? It's like, here's the diet. And there's so much that goes into figuring out, even on a personal level, like what is the ideal way for someone to eat. And there's so many things, like we live in a society where readily available like frankenfoods exist, and we might consider them, like if you talk to my grandma about what she thinks eating in moderation means, and me, we have different ideas. It's like a very small Venn diagram, right?
Yes.
um and is just going gluten free, and so I'm reading the book Dopamine Nation, and she's talking about how people will impose metrics on their eating in order to maybe eat more healthfully. So in the past, maybe even as little as 5 years ago, someone would say, I'm gluten free in order to improve my diet. Now what am I? I'm not eating cakes and hamburger buns and things. I'm eating whole foods. Nowadays, though, if you're gluten free, it doesn't
find all those things.
Exactly, like you can eat whatever. So it's not like, and for patients,
does not mean healthier.
Exactly.
Right?
And
dairy
I think
free does not mean healthier.
Exactly. Yeah. Because are you doing like, is oat milk and whole foods sort of like organic milk, or is oat milk better? No.
I think we're assigning like value or like more a moral value to foods at this point.
Free of things. Yeah.
Yeah, which is not, we should not be doing. So it's a challenge. And for myself, like I tend to feel best not having a ton of gluten in my diet, and that's it makes me bloated and makes me tired. So I don't have a ton of it, but if I like go out for pizza one weekend, hell yeah, I'm gonna enjoy my pizza. Or like if it's my birthday, I'm gonna have cake. And like that's just things that I'm going to enjoy, because food, as far as I'm concerned, is meant to be enjoyed and is one of the big joys of life. And I don't want it to be just a source of stress for me or my patients, right? And I think this is where we whittle and whittle away and whittle down our diets until it becomes so restrictive, and there's there becomes so much fear around food, and then we're dealing with a whole other beast essentially at that point.
Yeah, exactly. And I think, like, I guess the last thing I'll say about that is like, it's a lot of it, unfortunately, is trial and error.
Yeah.
I try not to like start with removal of foods unless there's massive indication that would be beneficial for somebody. But like usually we're talking about adding in some things that are beneficial, getting a food routine going, like balancing things a little bit more. Blood sugar is massive in my practice.
Getting more protein in the morning.
Like,
I'm sure
what
that's
is
like
protein? Like, before we start taking away your
100%.
food, let's talk about like what makes up a meal. And then developing awareness, which I think a lot of us could benefit from. There's a study from the 1930s. It was more like this observational study where this woman, oh my gosh, Clara something, she let babies self-feed. 6-month-old infants were able to just self-feed from a variety of whole foods. And her hypothesis was, or her question was like, well, do babies intuitively know what foods to eat? And basically their cravings guided them to choose foods and self-select. And there's like an interesting example that bunch of the babies, they're orphaned babies, and so a few of them had rickets, low vitamin D, and so they gave them cod liver oil, just like a little, like which if anyone's tried, is quite disgusting.
Not that delicious.
Exactly. And so they'd give them like a little shot glass, and the babies with rickets would just like they'd take it every meal until their D levels were restored, and then they were not interested anymore. And like, I don't know, that's obviously not highly controlled study, but very interesting. And so this wisdom that we might have had, how do we get back in touch with it? Like you said, if I eat gluten, I just don't feel well. So maybe on a night where I want to enjoy pizza, I don't mind being a little bit brain fog the next day. But if I have a massive exam, probably not going to partake. And how many people are constantly feeling brain foggy and sluggish and tired and have no idea what food it could be? So it's like restoring that not control, but awareness. And that's a lifelong thing. So
For sure. It's a lifelong journey.
yeah.
And, for me, how I eat now is different from how I ate 5 years ago, 10 years
Mhm.
ago, 15 years ago, and it
Totally.
changes in different times of your life. And I think that it ever is an ever evolving journey for sure.
Yeah, totally. Yeah.
Mhm.
And I think like, yeah, but to say like you have Hashimoto's, you can never eat gluten again is too simplistic. Yeah, it's like super simplistic, not fair to the person, very stressful.
Yeah.
If that person's like, huh, like I just want to feel better, like can just one inositol supplement be helpful for them? And then you see them in 6 months, and then maybe you start talking about adding in
Yeah.
greens or whatever, you know?
Yeah.
So
Whatever it is.
everybody's
Right.
on a
And
different journey. Yeah. So to like freak somebody out with a gluten-free diet that yeah is yeah, I think, and that's where our magic and our art comes as NDs, is that we're working with the person, we're just like trying to help them, we're collaborating in like what would be best for this person, and what in their opinion would be best for them as well, versus here's the diet you're going to eat, if you don't do it
yeah.
you're not going to get better. It's like that's
Exactly.
rarely the issue.
It needs to be a
Mhm.
conversation. And like I have been that patient in an ND's office where it's like your first visit and it's just like this blanket recommendation of like, okay, just take out gluten and dairy, like see you in a month. And I'm just like,
Yeah.
number one, not gonna do that because it's
Yeah.
a lot of work.
Yeah.
Number two, not gonna come back because I'm not going to do it. And like,
Mhm.
then that progress or that journey is cut short because it
Mhm.
starts with such an unrealistic expectation.
Mhm.
So
Mhm.
I really try to meet people where they're at and chat about how they're feeling about their diet, and get their own thoughts. And some people are really keen and ready to make changes, and they're like, I really think
Yeah.
this is something that's not good for me, and I'm ready to take it out and just give it a couple weeks and see what happens. And for other people, they don't seem to have any issues with it and they feel great. And we're more so like tweaking protein intake,
Mhm.
getting in lots of antioxidant nutrients, omega-3s, like really basic
Mhm.
stuff. So
Mhm. Yeah, like what
it's
are the
gonna
overall patterns? How can we
yeah,
improve those? Yeah.
yeah,
Yeah.
exactly. Yeah.
Katie, any last thoughts? Any take homes that you want to share with people? Thank you
Oh
so much.
man, I feel like we've covered so many different things today. I think that, for me, really the messaging comes back to for for women to not necessarily settle for, okay, yeah, like your TSH is normal, everything's good. Sometimes there needs to be further assessment and work that can be done. And sometimes you need to find a different or new approach or new practitioner to do that. So yeah, I would say always, nailing down that assessment piece, getting that full thyroid panel done, getting your nutrients done, and taking it from there.
Beautiful. Thank you. And where can people find you?
Oh, sure. Yeah. You can always find me on Instagram
Mhm.
at your.thyroid.nd. And my website. So my clinic is Rooted in Health in Barrie, Ontario. And then you can also find me on the Thyroid Academy, which is my new educational thyroid platform. So that's for professionals and patients or public. And that will be launching mid-April.
Beautiful. Thank you. Yeah, all
Yeah,
those links will be in the show notes for people
amazing.
to click on. And thank you so much. This was
Oh, it was
fantastic.
my pleasure. Yeah, it was great chatting with you. Great convo.